this morning. My name is Atandra Berman. I'm the founder and CEO of RCE. This is a company I started in 2018. So we're still under 5 years, so we probably fit within the 1 million cup category. We're a medical device company, so these things do take time. We're not FDA cleared, we're early stage. And I want to take the opportunity today to tell you a little bit about RCE. We are doing some of our FDA clinical studies in North Carolina. So I would like to end this call or the presentation by obviously asking the community for being supportive and potentially volunteering or spreading the word around. So with that said, I'll get started. I have a few slides here that I'd like to share. Can you please let me know if you can see my screen?
Yeah. There you go. We can see it.
Yeah.
Okay, great. Awesome. So I started this company back in 2018. It's called RCE. That stands for Remote Cardiac Enablement. And the context for starting this was, the reason primarily was I lost my dad to a heart attack, and it was a second heart attack. And I felt really compelled to do something about it. My background is in engineering and medicine, and I felt like there was a huge gap. When I looked into my own dad's situation, as well as many other people that I spoke to early in 2018, I realized that a lot of people don't know if they're having a heart attack or not. Do they go to the hospital? Do they stay at home? They have all this dilemma, and a lot of time goes by. And even if they get to the hospital, it takes a long time until they actually get true care for their heart attack. And so with that said, I wanted to come up with a solution that could really change the way heart attacks are diagnosed and detected in the world. And eventually my vision was, in 10 years, we should be able to have an impact such that we could see a fewer heart attacks in the world. And starting with the lens of where we see heart attacks most commonly, we look at the emergency departments today. So in the United States, we see about 10 million chest pain patients coming in, and they can have all sorts of presentations. They can have pain in the chest, they can have perceived pain in the back. We don't know, but all of these patients get the same treatment or the same diagnostic workup, which means you come in, they ask your symptoms, they might take an EKG, then they will ask the phlebotomist or a lab technician to come in, draw blood, and send it to the lab because they want to see a measurement of a certain cardiac protein. And this cardiac protein is called troponin. It is very specific and it's diagnostic to heart attacks. Now, one is never enough. You need more than one because you have to see a trend in this biomarker protein. And the reason is many of these patients who are older or people who are older have elevated baselines of this protein. Now, blood draw in the first place in an acute setting, in a state of anxiety, of knowing, of not knowing what you have, is very cumbersome. A lot of these people who are older, they are having they're on blood thinners. It's really hard to draw blood on these people. These people are diabetic. They might have comorbidities like kidney failure, and they might be on dialysis. So they have a lot of already access points that have been exhausted, and access to veins is really hard. So all of this is happening right there in the emergency department. People come in with chest pain, and you have 10 million people. Now, what ends up happening is most of these people, about 83% of these, are not cardiac. Now, that's surprising, but that is reality. Most of these people are either having indigestion, upper back pain, chest muscle spasm. They pull the neck jaw muscle, and they might feel perceived pain radiate on their arm, and they think it's a heart attack. So for the most of the people, most of the crowd that comes into the emergency department with chest pain, you did not need a blood draw. You did not need to be there with anxiety for hours. Now, after 4 or 5 hours, when you get you get a diagnosis, then you're advanced into the hospital for cardiac care. Or if after 5 hours you're found out that you don't have cardiac care, then you could be either discharged with to an outpatient facility if they need to do more workups. But most likely, if you have indigestion, you give them a medication and you send them home. Now, this is obviously an optical problem for the hospital. It takes up a lot of resources. It's a cost burden keeping these people in the hospital for so long. So the way, we came up at RCE with a completely disruptive technology. We reimagined the way blood draws and troponin was being measured. And we came up with an ambulatory solution, which is completely wireless. Now, this is an optical-based solution. And the way this works is a staff member, clinical staff member, preps the patient's wrist with an alcohol wipe. Once the alcohol wipe is done, this is basically done to normalize the skin surface from tanning lotions or oils, moisturizers. Once that is done, the device is turned on, and this goes into an automatic calibration sequence for 45 seconds. Now, this is done every time you power the device on, and this ensures consistency between measurements. Once the 45 seconds calibration is done, the device switches from this calibration to an automatic patient acquisition phase. At this time, the clinical staff guides the patient's wrist onto the sensor surface, as you see here, and then secure the patient's wrist onto the device with a wristband. And once that is done, you place the patient's wrist, you leave it on there for 3 minutes. And after 3 minutes, we're able to show the troponin concentration on the device. So during this 3 minutes, we're acquiring an infrared spectral map. And after 3 minutes, this data is collected, it's wirelessly sent to the cloud. In the cloud, the data is processed and immediately sent back to the device. So bedside, the patient, the staff, as well as the doctor can see the value of this troponin concentration. But not just that, this can be actually trended. So since it's non-invasive, you can repeat this and you can actually see this continuously for about however long you want. The current battery life of this device is 13 hours, so you can trend this for 13 hours. The point in this is that because it is non-invasive and continuous, you can actually see if the trend of this biomarker changes. If it's changing rapidly, you know this is a heart attack. If it's not changing, then it means that this person is not in an acute cardiac event. And that is very meaningful. And this can be done right as soon as patients walk into the hospital. Not just that, it can also be positioned upstream of the emergency department in ambulances, urgent cares, cardiology clinics, all these places where people with chest pain can walk in and they're not sure what's going on. They can get an immediate risk stratification. So that said, we're very excited. We've had a chance to move this technology forward. We've had, a lot of feedback from the hospitals. I'll run through a few slides really quick here as they're really technically detailed, and be happy to go over anything in specific at the end of it. But Trope Sensor overall is a very simple to use device. It's non-invasive and continuous. And as we have led through clinical validation over the last 3.5 years, we've had the chance to patent our technology. We've had the chance to validate this. We've built the technology from the ground up. We did the translational research to identify the infrared spectral region. We then took it into, we sourced blood samples and characterized them with infrared, and we verified that our optics, work. We then moved it into transdermal measurement to devices. We saw correlation in multiple clinical studies. These were published in Nature Communication Medicine. We were accepted to present at the American Heart Association conference last year. We showed correlation with different studies at UT Southwestern, at UCSF. We also, more recently in March of this year, presented at the ACC Late Breaking Clinical Trials. This was a cornerstone presentation study done at 5 sites, 239 patients. We demonstrated a very strong delineation of looking at patients with elevated troponins, which are having cardiac injury, versus normals, so who did not have any cardiac injury. We're currently now in an FDA study at 10 hospitals around the country, one of them being in North Carolina. This is in 1,040 patients. We're at about 650 patients. And again, we continue to show a very strong delineation between the acute cardiac injury or potentially heart attack patients with elevated troponin values versus normal, healthy people, like most of us here probably. And this is my favorite slide of all because this shows the future of cardiovascular medicine. This is where you are trending troponin continuously. This is a preclinical model done with Texas Heart Institute where we placed the device through the skin on a porcine subject, and we conducted an angioplasty procedure. So this is basically to advance a catheter into the one of the arteries of the heart in the porcine subject, and you inflate the balloon for to basically occlude the whole artery for 90 minutes. So you're inducing a heart attack. And what you're seeing between these red lines or the black arrows is trope sensors readings rise very quickly from baseline as soon as you start seeing an induced heart attack. And we took this blood and we sampled it and we sent it to different labs, and we saw a strong correlation with blood-based assays. So very exciting. This really paints the picture for the future of medicine, where you can actually put this, you can envision the technology to be on someone and they can go to sleep. You have a baseline, and then you're able to track as soon as you had a heart attack. All that said, I think we started to look at the market. I'll share a couple of slides here and then I can end. The market for troponin is huge. We realized that this is over a $2 billion market just today. And, in speaking with over 25 hospitals, I asked, like, how would you use this technology? Would you see value in this technology? How would you price it? How would you pay for it? Why would you use it? And a series of interviews with customers gave us an insight that today they were willing to pay, they were actually paying $35 to $45 for point of care devices that were not accurate. And so we believed, after discussing with a lot of these directors of emergency departments who would buy this device, that they would buy this technology for $50 per read. So you buy the device for $1,000 to $5,000, and then you would pay $50 per patient. The reason they would pay that money is because that helps them make a quick early diagnosis, and that does two things. One, the majority of the patients, 80%, they're able to make a decision and they don't have to keep them in the emergency department. They can start to discharge them sooner as in within an hour. That helps unclog the busy, crowded emergency department. The next thing they can do, which is of high value to them, both from a patient outcome as well as a revenue perspective, is they can accelerate the high acuity patients. So the cardiac patients who really need care, within 10 to 15 or 20 minutes, they can make a decision. They can accelerate these patients. Once you make a diagnosis, you can move from an outpatient setting, such as the emergency department, into an inpatient setting, such as a cardiac monitoring unit, or advance them further after testing into cardiac catheterization procedures. So the reimbursement for observing someone with non-cardiac is very low. It's about $800 per Medicare, versus the reimbursement for cardiac patients who are going in for procedure is very high. So the hospitals see this as a value add. They would rather spend $50 upfront such that they can accelerate the $30,000 to $60,000 patients into the hospital quicker. So all that said, I'll end here by just showing the future of cardiovascular medicine with trope sensor. We envision, obviously, this is a technology that will be ubiquitous throughout healthcare. It should be. This is people like my dad and many of people that you might know might have cardiovascular disease. Heart attacks can happen to anyone, anywhere, anytime, and we ought to have a technology that can follow the patient. It can be patient-centric. We look at certain positions in the hospital system today, such as the emergency department, urgent cares, ambulances, cardiology clinics, all these places where there are acute settings where people show up or get picked up or reported by bystanders that might have a heart attack. But then on the other side, once patients are diagnosed, either in an acute setting or in in a stable setting, they're able to identify heart disease, and we are able to monitor these patients post diagnosis. There are other scenarios such as heart transplants, obviously post procedure, there are repeat heart attacks. Many of these areas, there's propensity of having heart attacks within 30 days after being diagnosed or intervened. So there's opportunity for the market to really develop here in the post scenario, which does not exist because of because of no feasibility with blood draws, and that's where we come in. I'm going to pause here and see if this was helpful, and I'd love to take questions, dive into more details, and then at the end, when